Okay, there we go. We'll go ahead and get started right now. So welcome to our Time to Act Substance Abuse Echo. Really excited to have you guys all joining today. We are recording this session. It is stored on our Canvas page as well as our YouTube channel. So hopefully you are just fine being recorded. If you've never joined an Echo, Echo is really interactive. So please put your contact information. If you feel comfortable, turn on your camera so we know who is on the call. It's always easier to be a presenter when you can see faces versus just blank black screens. We also will always do a case presentation. So if you have a case that you're unsure of, or you just would like some kind of feedback and information on, please consider submitting a case presentation to us. But we do also talk about some sensitive topics. So remember to de-identify, protect our clients and our families' individual privacy. If you have any questions about what might be confidential, you can always reach out to a hub member. They have an asterisk or will now have an asterisk in front of their name, and so they're easier to find in chat. Key components of an Echo is always having a didactic speaker. Then we will have a case presentation where everybody on the call shares recommendations. You guys are all amazing experts in your field, and it's so cool to hear all the things that you guys are working on with families and clients. We then store the recommendations on our Canvas page, so you are free to go back and reference those or get those for the clients that you're working with. We send it out to the person who presents the case, but there's sometimes that you want to go back and see what other people have talked about, and it might be a case that is similar to one that you're working with, and so knowing what some people recommend or some resources and strategies. Again, if you'll rename your profile so that we know who's on the call, are able to talk to each other. Maybe Erin Matson, she's on my screen, I can see her. She might share something amazing on this call, and then I would know who it was and how to reach out to her. So that's why we ask if you'll rename your profile. Just build that professional networking that we do when we're in person, but virtually it's harder to do, right? If you want to raise your hand, you can do that, or you can just put your question in chat, and Kurt Phillips monitors that for us. Pre-registration allows you to receive information for the sessions beforehand. So you can reach out to projectscope@usu.edu, and then how to get that certificate of attendance. Throughout today's session and after today's session, Shana will put in our survey. After you complete the survey, and once a month, we do send out those credit certificates of attendance. Canvas, again, if you've not received a Canvas invite and want to have access to all of our Canvas pages, you can email us and just put Canvas in the subject line. Again, another plug for those case studies. This is a great way. They're my favorite part of our Echoes, is because we get to hear from everybody on the call, ways to support the families that we're all working with. And sometimes these are challenging families and have interesting backgrounds. And so knowing what somebody might do down in southern Utah versus what we do up here in northern Utah is certainly helpful to know and hear those things. It is sometimes scary sharing a case. So if you're nervous about that, but you want your case shared, just reach out to me. I'll be glad to present your case. That's what I'm doing today. Somebody reached out to me and asked if I would present that at our Echo. and then be able to get those results. So please consider doing that if you're interested in that. Again, we do have some social media. So while I turn the time over to Kyla Clark from Division of Children Family Services, who's going to share with us today, you can take a minute to follow us. So I'm going to stop sharing and let Kyla come on.
All right, and I am still working on figuring out this office camera. So if I look crazy, someone just wave and help me be uncrazy. Excited to get to talk to you a little bit about the DCFS system today. Just to echo what Janelle said, these are always more fun if you ask your questions. I have a presentation to go through, but we can stop at any time to kind of chat more about your specific questions related to working with the mysterious and wonderful Division of Child and Family Services. So we start out with just our mission. Child and Family Services mission is to keep children safe from abuse, neglect, and provide domestic violence services by strengthening families and working with communities. I do have with me today on today's Echo, Erin Madsen, who is one of our domestic violence administrators at our state office, as well as Daniel Rich, who is over our CPS investigations. So they are other resources for you with your DCFS questions. And then we have our vision, which is safe children and strengthened families. We're really looking for how do we connect to services and keep children with their families whenever safely possible, or if they do need to come out of the home, how quickly can we return them to a familiar setting? So with that, we'll talk a little bit about the journey through DCFS starts with a call to our intake line. Congratulations, if you didn't know, everybody on this call is a mandatory reporter in the state of Utah. Everybody in the state of Utah is a mandatory reporter. So if you see abuse or neglect, this is a phone number that you should be able to Google. It comes up real quick. It is available 24/7. We do have a professional reporting line. So if you are maybe through a home visiting program working with a family, you could submit your referral through that website. All referrals can be made anonymously, or you can leave your name if you want to be contacted as part of the investigation. Any questions on reporting? Hopefully that wasn't news to anybody. Okay. So when to report? Sometimes we get a lot of questions about what we actually respond to. So signs of abuse in a child might be injury, withdrawal, unusual sexual behavior, abnormal aggression, major changes in the behaviors you're seeing, strained relationships, these appearance of being fearful around caregivers, bedwetting, passivity, and suicidal comments. Signs of neglect in a child might be hunger, stealing, being out unsupervised, inappropriate clothes for the weather, improper hygiene. Any thoughts or questions on that one?
Kyla, I have one question that I know that comes up pretty frequently in our Part C early intervention programs is when we're thinking about doing a report, how do we inform families, or what are some ways to do that? And that makes sense. Like,
so I think that you're going to get really annoyed because I'm going to start with that sort of depends on the severity of what it is you're seeing, right? Like if I'm worried that the family, like if I have a conversation with a family about the bruises, but I'm worried that they're going to pick up and move across state lines, you probably don't want to have that conversation. 9 times out of 10, though, a lot of what gets reported to us is the stuff that we've been trying to intervene on already, and we're not seeing that behavior change, or we're continuing to see inappropriate parenting, right? We're continuing to see the spanking or the hitting, or we're continuing to see the non-supervision and the kids getting out on the road. And that's typically, I would say, if you're already having those conversations, from what I've seen with cases with early intervention, you're already starting to mention some of the like, hey, maybe we should keep a better eye on that, or hey, maybe let's try a different way of handling it when we're stressed out, if that's been a kind of a course of the escalation, it's easier to say, hey, look, I'm really concerned and I'm probably going to have to call intake to screen this because I feel like we've talked about it and it's not changing.
Great, thank you. That was helpful.
Any other questions? I think that's a really great, I think that's a fine line, right? Because you don't want to mess with your relationship. But I often, and sometimes it's not. Sometimes we'll get a referral and early interventions in there and the family will assume it was early intervention and it's not. But having as much transparency in that conversation with the family is going to be your best bet. Unless you have real pause. Like if you see something really, really scary, you may want to call us first and not give them that heads up, but that is the exception, not the rule. Okay. So what if the alleged abuse occurred in another state? So any of my people on this call in like Southern Utah along that I-15 corridor, because we get a lot of situations where the family might just be here for a brief moment. Now, probably not involved in services, but just so you know, DCFS cannot investigate abuse that did not occur in Utah. That also includes any disclosure of stuff that may have happened when they were in another state. The other piece is that we have to be able to actually locate the kiddo. So where you guys are already going to their home, you usually can tell me where it is. When we get to our screened out calls, that's a big majority of them is people call and they're like, something bad happened at the Walmart. But if I don't know the kid's name and I don't know where to find them, I'm not able to open a case. Okay, I'm going the wrong way. And again, if they've moved, we'll look there, but that's part of that conversation of if we're worried that they're going to kind of leave the state, we may not want to do a heads up. So this is where we want to spend a little bit of time because a lot of your programs may start prenatally. So DCFS does not respond until a child is born. But we do have a deferral process to the Office of Substance Use and Mental Health that then connects to the Office of Home Visiting to offer supports and services to the pregnant person. And I'll share with you some stats on how we're seeing that deferral program work. Other states that have gone on to let DCFS respond to pregnant women have seen an increase in women actually avoiding prenatal care to avoid DCFS. And the unintended consequences are way worse. So we have been studying this with the Super Rad Clinic. I believe Dr. Smid has spoke to this group before. We worked really closely with her on creating this legislation to have it be more of a treatment-focused approach while they're pregnant and substance using. In the ideal scenario, we're connecting them with treatment and not needing a child welfare response. Okay. So that's where the conversation of plan of safe care comes in. And so women who are substance using and pregnant, we're really trying to get to where we can create a prenatal plan of safe care. So earlier detection of substance use, more likelihood of catching, getting into recovery before the child is born. We all know, everybody on this call knows, the longer they're exposed fetally, like the worse the outcome is. So the sooner we can sooner we can connect, much better word, connect women to treatment and intervene, the better off we are for that mother-child dyad. So plans of safe care can be created prenatally. They can also be created at the time of delivery. So if at the time of delivery, the parent is still abstaining from use or is only testing positive for THC, DCFS does not need to be called, but an early intervention program like many of the ones on your screen could be used by the hospital social worker as a home visiting option to monitor the health of the baby without needing to come to DCFS. If you think about child welfare, we're actually a bigger system than DCFS. DCFS is the last caboose of taking care of kids. Like all of you on this call have some role in child welfare, right? We have these early intervention programs. We have these things that really try to get kids on track long before the abuse and neglect ever happens. And so what we're really doing with Plan of Safe Care is how do we utilize these other interventions great services that your systems offer to help negate the need for child welfare. I mean, we're still here if we have to be, but much to Janelle's comments about, if it's not working or if we are still seeing concerns, we will definitely still be here. But the goal is to really have Utah have a softer approach whenever possible, because we're scary. I don't know how many of you would be excited if DCFS knocked on your door for your kid or grandchild. There's an inherent a bit of stress that comes with that. So if I'm a parent in early recovery and I just delivered a baby and I have all of the hormones that come from just having had a baby, and now I've got a CPS worker trying to be nice, but asking me some pretty scary questions, I've kind of created a recipe for relapse, and we're really trying to look for how do we not set up women. One of the other places we see some really great time of delivery plans of safe care are women who are in some of our residential treatment programs already. So that was a population that DCFS was still responding to, which didn't make any sense, because if you're already at the highest level of treatment and you did this before the state made you, what is having the state come tell you to keep doing that do? And so it's giving us an opportunity to really think through where is this parent in their journey of recovery, and do we actually need DCFS or do we have other interventions, knowing that DCFS is always there if things go sideways. And then part of that legislative change in 2020 did have some changes around THC only. So DCFS does not have to be called if THC is the only substance in a mother's system at the time of delivery. That being said, DCFS is still called if we are concerned about their ability to parent the child. So it's really about the impairment and not necessarily the presence of THC. Any questions, thoughts on that? That's kind of a lot of topics on one slide with only like 5 words on it. Okay. So just by way of outcomes, because I think when we talk about these sort of things, people always want to know, like, how is it working? So at the 2-year mark of the cases that we did not open because they were THC only and they were sent to the Office of Substance Use and Mental Health for support, 79.5% of those have never come back on our radar, which means we have never had even a call to our intake line about them. 8% have had a CPS investigation with no further involvement. 4.5% have gone on to have some sort of in-home service. So that means DCFS is involved, possibly the court, but not necessarily. But they keep custody of their children. And then 8% of them have actually come into foster care. And I'm trying to think, Dan, off the top of my head, this is, when we talk about these 2 years, we're talking of roughly 200 women, 150?
Yeah, last look, I believe it was around 200. Yeah.
So we consider that to be really great. That may be an indicator that in the past we had been overly intervening on this THC. We continue to look at it. Dan and I look at these numbers every month. We compile things annually to make sure that, we're getting the results we want from this legislation and not leaving any undue risk. The other population is the calls during pregnancy. Now, this one doesn't have as high of no further contact, but a lot of times that is because these calls will come in from law enforcement. Some of these women are homeless. Sometimes we're not actually able to connect them to services. This is the group we would love to see more movement on. This is where we continue to try to engage with primary care physicians. And it was interesting, we did a survey for Plan of Safe Care, Dan and I did, with emergency rooms and Instacare clinics, and they were like, oh no, this isn't our world of, we're not really in this. That would be OBGYNs or general practitioners. But then when we did a listening session with women with substance use who had experienced pregnancy, the vast majority said they found out they were pregnant in an Instacare or an ER, and then they didn't have standard insurance, they didn't have a GP, they weren't going to an OBGYN until way closer to delivery. And so it is kind of as a system, when we're looking for our opportunities for improvement, that is a sort of a gap in connecting the dot, right? Like that service industry doesn't see that as their role. But for the clients, that might be the one and only time they are interfacing with a doctor, or one of the earliest times they are with substance use and pregnancy. And so really looking for those opportunities to maybe connect those dots better for these plans of safe care in the future. And we've talked about, is that service navigators, is that nurses that could help connect, is that, what does that look like as a broader child welfare system to support that? So the calls received about pregnant women, 50% of them do go on to not having another call to us. About 10% get a CPS investigation, but no further services. 13% go on to in-home supports, and then about 27% do end up entering foster care. Fetal exposure is one of the #1 reasons for removal. Substance use in general is the #1 reason that there are kids in the foster care system in the state of Utah. Questions or thoughts on that? Dan, did I miss any key points? Dan has been on this law change and plan of safe care journey with me for about 5 years now, so I want to make sure I do it justice.
Kyla, will you restate that statistic again? I don't know if I caught it, where you were saying about the opioid exposure, the highest in Utah.
Oh, so the #1 reason kids are in DCFS custody is substance use. So about 72, it varies between 72 and 75% of the removals in the state of Utah are for parental substance use. All of the rest of our allegations, sex abuse, physical abuse, parenting issues, educational neglect, dependency, makes up that other like 25 to 29%.
And is that always the ones that are born exposed, or just throughout their?
Throughout the lifespan, yeah.
Okay.
So fetal exposure is a big portion, but it's any of the lifespan. Substance use is 72 to 75% of our cases, but it's throughout the lifespan of the child. But parental substance use is the reason they come into care.
Okay, and then there's also a question on, is there data on which substances are the primary ones?
So Utah still our primary, so I also oversee our drug testing contract. So for families involved with DCFS, the #1 substance use still is opioids, but we have methamphetamine trending very close behind at this point. So still have a lot of opioid use in the state of Utah. It is the #1, but methamphetamine is back on the rise, seeing numbers that they hadn't seen probably in the last 10 years. So.
And Kyla, when you talk about other allegations, whether it's like physical or sexual abuse, do you call it allegations because it's too hard to prove? Is that the reason?
So juvenile court works in allegations, criminal court works in charges. And that's one of those vernacular differences that can be really confusing, because some of our allegations also result in criminal charges. So if you're in the juvenile court, you have allegations. If you're in the criminal court, you have charges.
Got it. Thank you.
Yeah, no, that's a great clarification. Any other questions? And then just for anyone that might be working with a disability population, DCFS is not able to investigate if the victim is over the age of 18. Those do get referred to Adult Protective Services. So when we talk about what is not abuse, we will not be investigating poverty, homelessness, or cultural differences. We get calls, like when we talk, again, I'm going to show you a slide in a minute about things that get screened out. A lot of times these are those. They are not statutorily abuse or neglect in the state of Utah. So the 3 things intake needs is a child, so someone under the age of 18. There's that allegation word again. The alleged abuse, neglect, or dependency, and then a way to locate the child. So we have to know where the kiddo is. And that's where we're kind of that, oh, I saw a mom hit a kid at Walmart, but if I don't have a name and I don't know where they went, not that I'm advocating that you like chase anybody down in your car after you see them hit them in Walmart, but we're not able to find them either, which can be a source of frustration sometimes for people. So intake will staff any call that comes in to see if it meets those 3 minimum requirements, and then it will be accepted or unaccepted, and we'll let the referent know. So the person who's calling in is told the decision at that time. If it's not going to be accepted for investigation, it'll get documented. We may offer services, that connection to APS. We may let them know it's getting deferred to Office of Substance Use and Mental Health, and then the referral will be closed. This is our intake administrator's contact information. This slide will be available in the Echo session stuff on Canvas. So you should have this. She's able to answer more specific questions. Don't call your allegation into her. Call that into the intake line. But if you have a question about something that maybe you've called in, or more of a general, more wanting presentations on our intake process, Marnie is here for that. So when we talk about what types of allegations we have, here is the exhaustive list, and you'll see abuse, fetal exposure is considered under abuse. And then you have your physical neglect, environmental neglect, medical neglect, your failure to protect, non-supervision. Those are going to be under here. Your child endangerment is where, so fetal exposure is your baby, child endangerment is where you're catching like your 4-year-old that's exposed to substance use. And those two combined comes to that 72 to 75% of our removals. The rest of these make up that 29 to 25%. So if you are going to have a CPS investigation, all of them are assessed a priority. Priority 1, the 1 hour to respond, is fairly rare. Dan, I don't know if you have a stat on that, but rare is usually the word I go with on it. Most things are going to be a priority 2, which means 24 hours for us to respond. And by respond, that means to see the child. The first thing that CPS needs to do is actually lay eyes on the alleged victim. So the child that was called in about. Priority 3 has 3 business days, 3 working days.
Kyla, do you guys warn them that you're coming? Do you let them know ahead of time?
No.
No.
And so these are some of the things that you hear kind of these things. We see the child first, and we see the child first because some of the situations we are in are pretty severe. And if we let the parent know we're about to go interview the child, the likelihood that the child gets coached increases, right? So we want to make sure that we are getting the information from the child before others have had more opportunity. They may have already, but additional opportunity to tell them what to say to the investigator.
Great, thank you.
So it is a recorded interview when they see the child. They will interview both parents or any legal parents. They will interview who the alleged perpetrator is. So whoever they are saying did the abuse or neglect, whoever the person calling intake said, this is the person abusing or neglecting the child, that person will be interviewed. This is completed through unscheduled home visits. So that is when CPS shows up without warning you ahead of time. We do complete those collateral interviews, and that's somewhere where something like a home visiting program, like if CPS knows that there's Root for Kids that's been coming into the home, you might be part of that collateral conversation to say, hey, especially when we talk about things like bruises. A lot of people on this call are child development experts. My brand new CPS workers may not know we do a lot of training around sentinel injuries and what is a normal bruise and what's not, but getting collateral information about, hey, this one's a little iffy, right? Like, let's talk about it, is a role that you guys could definitely play. We do have a actuarial tool called the Structured Decision-Making Tool. It's a safety and risk assessment. That's what SDM stands for, and that is completed. And then we have 30 days to make a final decision. That doesn't mean every case takes 30 days. Some may take longer. Some that are egregious will be much shorter. It's not like if we are like, oh, this kid is absolutely being abused, we're going to leave them here for 17 more days, like that's not it either. That's just a time frame for us to make sure that we have things moving and that they're not lingering. Any questions on that? Dan, anything I missed? Hi. So we look at our structured decision-making tool. It comes out with our safety assessment, which is really, really looking at currently what's going on. It's the incident that's right now. And then our risk assessment is that actuarial tool looking at the potential for future harm to the child. And then we have supported, well, we have not enough evidence. We have 4 types of findings. We have a not supported, which doesn't mean didn't happen. It just means there's not enough evidence, kind of back to your question earlier on the allegation. Sometimes we just won't be able to get to enough information to take it to a juvenile court or to support a finding. Without merit is really saying that when we investigated that this is not a valid referral, like this might be something being done out of spite. I don't know, Dan, if you want to take these, you might have better wording for this. I'm watching your face.
Oh, you're good. You're good. Yeah, without merit is you just know for a surety that it didn't occur. For example, the person that the abuse was alleged against was not in the state at the time or did not have contact with the individual. So without merit, you just know for a certainty that it didn't happen. It can also be very similar to the last one, a false report. Sometimes we do get individuals that call in false reports against people because they're mad, they're upset, whatever that may be. So they call DCFS and fabricate a report. And if we do know it's a false report, we should be reporting that as well. So that is one of the other options. And then the unable to locate, or there's also an unable to complete. Just means we couldn't find the child, we couldn't interview the child for whatever reason. We didn't have access to them, or we don't have enough information to make that finding. So we do have that option in case we can't find the family or we're unable to interview the child.
And if a case is going to be in any of these not enough evidence found categories, that doesn't mean we can't still connect to community resources. We may give links to the local mental health authorities. We may make referrals to some of your programming as well. Oftentimes we will see what my supervisor always called wonky parenting. It's that parenting that's questionable, but not abuse or neglect. Those are things that we may then leave community resources for an early intervention program. I did my casework in Salt Lake, so it was a lot to DDI Vantage for to say, hey, you need a little parenting support, or we've got a kid that might be having some developmental issues. We need a community resource in there, but not child welfare oversight. So if the case is supported, we will create a safety plan to keep that immediate child from needing to come into care. And then we can offer services. We have a collaborative service, or our PSC service, which means that there is no court involvement, but there is an ongoing case manager. Or we may seek court-ordered in-home services, which is our PSS, or Protective Services Supervision. That sounds like Yoda said it. But that is when we have court orders for interventions. And you may get referrals from us for that as well. And I don't really know why I suddenly became foggy, but apparently I'm foggy. Okay. So here is the data from 2022. Our intake referral and our intake hotline in a year receives about 38,500 phone calls. About 22,500 of those are accepted for CPS. And then about 10,000 wind up in confirmed reports of abuse and neglect. And from that 10,000, about 3,200 go on to having some sort of, 2,200 go to in-home. We have about 1,900 going into kinship placement. And then we have kids in foster care, which is weird that this slide, I haven't seen these since Miranda changed them. Did we lose how many went into foster care? I will get you a number on how many went into foster care because my slide is missing a line apparently. We have a new public information officer to make all of our things say health and human services. And so some of our slides have undergone a small transformation. So goals, whenever DCFS is involved, our goal is to try to get children to their home of origin. So children remain safely in home. For PSS and PSC. For SCF, we always start with a goal of reunification. There are a few exceptions for extremely egregious situations, but they make up less than 1% of the cases we're ever involved in, like less than 1/10 of 1%. And so very generally, all of our foster care cases tend to start with a reunification goal. If not that, then we look at another permanency. So either with an additional relative, guardianship or adoption, we look for kinship first. We also have, if we do have youth that are older, they can do some individualized permanency, meaning that they are aging out intentionally on their own. So when we do have ongoing services, we really look at how are we developing safety. A lot of parenting skills go into that, a lot of treatment. So our substance use, conflict resolution, problem solving skills. We have a decent cross section of the substance use also has a domestic violence component. So a lot of domestic violence treatment, a lot of conflict resolution, a lot of ways of better managing stress in your home. So this again, just as a recap of the priority of placement, if you do need to be removed, the first person that they would look at is any parent not living in the home. So if this is a divorce situation or, they had never been married, but there's a non-custodial parent, that parent is explored first. Kinship is family, and then we have close family friend, which also falls under that kinship. So someone, the term that we're using right now is familiar faces. Who do these kids know is a place that they can go while their parent works on the things they need to have that reunification. Then we have our foster homes and proctor homes, and then congregate care settings would be like residential treatment. Those are usually, not usually. Kids in these are only experiencing their own mental health issues. Like we are not putting kids in group homes or residential, like we don't have orphanages in Utah. Congregate care settings really are when it's a treatment need for kids in our custody. Any questions on any of that? How am I doing on time?
You were good. You have about 10 minutes.
Perfect. Okay. Well, and the last thing I really want to spend highlighting is as we go back to that population of fetal exposure, Utah is very, very lucky to have a great network of parent-child residential treatment programs. When we talk about things that lead to the best outcome, so 75% of our cases have substance use in them. In general, it's about 50-50 on whether or not reunification is successful. If a kid comes into care for substance use, it's about 50-50 whether or not the parent, because of federal timeframes, we only have a year. And everybody in here who's familiar with addiction knows that's a really short time frame for the disease of addiction. And so it's about 50-50. And a lot of people, if we catch you at the right time and that readiness for change, where you are in that cycle, those things work out really well. And we have some great sobriety success stories. Unfortunately, we also sometimes are kind of late into the game and they're not ready for that change. And we do see adoptions come from these substance use removals. One of the bright spots, after I share depressing 50-50 chance of getting your kids back, we do have these parent-child residential programs, and people who complete these have about an 80% reunification rate. And about 76% of those are still reunified at the 4-year mark. So this is probably one of our most successful programs. They are residential facilities that allow the children to live with the parent. All 5 serve women. Odyssey House also has a home for men, for fathers and children's. Each of these programs looks slightly different, but they have on-site childcare, therapeutic preschool, or therapeutic interventions for the kids. And it's an opportunity to learn sobriety while parenting. A lot of it is because we know sometimes it's great to get sober and your kid's over here, but then kids are stressful, and that reunification of your child is a great happy moment, but it also may tax some of the skills that you have that you haven't gotten to practice sobriety while parenting. So we see some really great things about this. Kids can be placed immediately out of the hospital. Sometimes they'll be in foster care for a few weeks to make sure that the parent is actually going to stay in the program, and then can be placed with the parent. These are programs that are federally reimbursable, because even at a national level, they're seeing that they're really successful. We get all the time other states jealous that we actually have 5. Some states are trying to set up 1. But I will say we are seeing a decrease in people being placed there. It dipped under COVID, obviously, and it's never really recovered. And so we're trying to look at what might be some of the bias or some of the reasons why these placements aren't being utilized as much. So we would love to see the women who need to get there. And so we're doing some outreach, again, that connects back to those plans of safe care. And so anybody that may be in a hospital system, knowing that these are an option and having conversations with pregnant women about this prior to delivery. We can always share out more information, referral documents, all of those sort of things to these.
And are those located throughout the state, or are they?
Yes. So House of Hope and Odyssey House are in Salt Lake County. House of Hope also has a Utah County location. Tranquility Home is in Weber County. Valley Phoenix is also in Salt Lake, and Desert Haven is in Iron County. So we don't have anything in the eastern section. I would love for us to get something out there. Any other questions?
I do. I'm so sorry I keep being the one to ask questions.
No,
but
don't be sorry. You're making my day here. Don't be sorry.
I'm so glad to hear that. So what is the longest stint you can have a child who maybe is down at the JCC, the juvenile, or JRC, the Juvenile Receiving Center? Is it 72 hours before you go to like a court hearing if there's more evidence? 48 hours?
Dan, do you know that one for sure? Because I know it changed a little with JJS's early intervention. Like if you are engaging, like if you go 72 hours and don't actually engage with your child, then they may call us. But their early intervention programs have some where they're using the JRC more as respite and they can be there longer. So I don't know that it's quite as hard and fast unless you drop them off and you're not responding to.
So let's say a child comes in, I guess, to your care and is put in a temporary foster home. At that point, do they, I'm assuming there's an emergency court hearing within so much time.
Oh, yes, sorry. Yes, a shelter hearing. Anytime a kid has been removed, we do have to have a court hearing within 72 hours.
It is 72. Okay, that was
Yeah,
my
it is 72 hours for the court hearing.
Perfect. And then you talked about your safety assessment. Is there any way that we can take a look at that? Do you have a link, or could you share that at all with us?
Yeah. I'm so glad you're here.
Yeah, I don't think it's a problem. We have like a SDM manual, the structured decision-making manual. Let me just verify, but I don't think it's an issue to share out to the group, so.
That would be awesome. And then my last one is, you talked about, like, obviously reunification is the goal, which is great. And sometimes they have to go through classes through you all, like conflict resolution, among other things. Do you have that public so others can access that, agencies like mine, if we see a family struggling with conflict resolution?
So we don't actually do any classes internal. We contract for all of our things.
Okay.
And there is a public list of all of our RAPS contract. I can put that link to there, and you can see it. It's an approved vendor list under state procurement. So everybody that's on that list is just public record.
That would be awesome. Thank you. I'm done. Thanks.
No, that was great. So my question, I guess, to this group is how many of you have in your role had an interface with DCFS or a client that might be mutual to us? You can throw it in the chat or, oh, got a hand up. Janelle, is your hand up because we're done?
No, I was
Oh.
just raising my hand that I've had a client.
Oh, yes. Oh, that's a good way. Yeah, we could do a hand indicator. That would be a good way of knowing. Oh, wow. All right. Well, I know Olivia has because
I was gonna say, I was like, gonna say all my clients do.
I'm like, I feel like you are honorary DCFS, like you have like little DCFS letters after all your other letters.
Yeah, I'll take it. I'll take it.
And Olivia is with the 0 to 3 Safe Babies Court, which is another place that is a treatment court option in Utah County for families that have young children and are experiencing the child welfare system. They're not required to have a substance use allegation, but I'm willing to bet the majority of the ones that Olivia has been involved in have, to some degree, involved substance use.
Yep. I'll confirm that.
I was going to ask you, you probably already know my situation. I've shared it a bunch, but one of our children that we adopted, we got her 2 days after she was born, but there was no chance of reunification for her. It was one of those extreme situations. But I've always been curious, between the birth mom and the birth father, they had lost probably 5 kids previously to DCFS. But I guess what I wonder is, would it be more related to that as to why the extreme measure of no reunification, or would it be more of the behavior at that time? Does that make sense?
Yes, and it's a very good question, and I hate my answer, but it does sort of depend on where you are in the state. So some of the judges really do not, like, they'll hit a brink after a few removals of multiple kids of where they're just like, nope, we're not doing this again. Other judges are more lenient and will continue. Like I had one 10 years ago when I was a caseworker that was on her 14th child, and we still did.
Oh my word.
Still tried to get her into services. I tend to be more on the lenient side, only because I also do our repeat fetal exposures. And so I see that when we don't offer it, when we offer services, we have women that are successful and we have women that get a period of time before the next child. When we don't, we'll see in a 3-year time span 4 pregnancies, and it's just kind of mind-blowing. And so from a harm reduction almost type perspective, it's like, why not keep trying? Simply because if it's not going to be successful this time, can it be successful to prevent a future fetal exposed baby? Like,
right.
And so that's sort of what they're balancing. But it's also, I think we have judges that look at it as the state pays for the services when we court order services. And at some point, there are judges that are like, I don't want to use taxpayer dollars that way anymore. And you had 5 other chances, and I don't think you're going to do anything different this time. So the continual fetal exposures would kind of put it in that bucket. That is one of the categories where they consider can consider not offering reunification.
Okay.
That's a great question, Tiffany.
Thanks.
All right. Well, Janelle, I think I used all of my time. And if you guys have Tanya, if you have other questions, anyone on here who doesn't want to ask them but wants to email them, I love a good question. So please.
And Kyla, did we get your email? I'm so sorry. I don't see it.
Yeah. So my email is Kyla Clark, and I can put it, I'm going to stop sharing and I'll throw it in the chat. And Dan and Aaron, do you mind if I throw you under the bus and have you throw your emails in too for questions? Aaron, again, is our domestic violence administrator. So if you have questions where you maybe have concerns on a home that you're working with, where there may be some domestic violence questions, she is great. And Dan is over our CPS investigations. And I can always, if you send them to me, I can always go through there. Yes, Desert Haven is in St. George. Sorry, Maria. Yes.
And then Dan, are you going to check on if you can share the safety stuff with us? And if you can, I don't know if you email it out to the whole group later or.
Yeah, I'll check on it and see if we can. And if we can, I will reach out to Kyla or whomever is in charge of the group and get it to them. So.
Yeah, we can get it to Janelle and Janelle can put it on Canvas.
Thank you.
Kyla, that's always so super helpful. I always learn something new every time you do this presentation, so I appreciate it.
But we're a big, complicated agency, so, and people always ask different questions each time, so I love it.
Right. I'm always coming at it from the early intervention standpoint, and we get those CAPTA referrals quite just that automatic referral, and wondering, just texting and chatting in the background to Kurt saying, do you think that our providers actually know that substance abuse might be the reason? And maybe we need to hit that a little bit more. So it was interesting, super helpful. Thank you.
Well, I appreciate the opportunity.
Okay, well, I am going to move right into our case presentation. And like I said, our case presentation was sent to me and they asked if I would just present. So I don't have a lot of kind of follow-up background information. This child was a 3-year-old and it is coming from an occupational therapist. The child was born at 38 weeks, but mom was really unaware of the pregnancy until 7 months. She received the medications for opioid use disorder throughout her pregnancy at 7 months, as well as taking non-prescribed opioids. The child then spent 2 weeks in the hospital due to some withdrawal. And when they were discharged, the child went directly into foster care and was reunified with the mom shortly before turning 2 years old. A little bit about the background is during her time in foster care, they were doing early intervention part C, and they also were getting some services through the visually impaired preschool. So in Utah, we call it Utah School for the Deaf and Blind, or PIP services. They did receive a visual diagnosis for visual alignment, as well as CVI. The caregiver was provided during when they were in the foster care system. But birth mom shared that she didn't get any services reinitiated up when they got her. The child has aged out of EI services, and they are working on open referrals for speech and psychology evaluations. The primary concern is that during the OT's evaluation, the birth mom is really missing important education, such as like what are developmental milestones, education or knowledge on existing diagnoses. And so they're really looking for some best ways to engage family in the patient's care when they're reinitiating services, and also just that education on medical care and diagnostics that was completed when the child was in that foster care system. Some goals that they're really working with is how to engage family in reinitiating therapy, And then the best ways to ensure that the parent is aware of what's happened currently and in the past. Some of the strengths is that mom is a year plus without opioid misuse. And she's really motivated to help her child in whatever way possible. She has support from the maternal grandmother. Some of the barriers are that we all kind of face is that they are that time to attend therapy is limited. And right now they are choosing a one OT appointment once a month, despite that weekly therapy was recommended. The health literacy and general understanding of some of the complexities of the child's medical care for the mom and maternal grandma. The strategies that have been tried is active parent education and training during sessions. So if they are trying a strategy with a child and the parent then practices that strategy during the session with coaching from the therapist. They've also recommended some toys that could be purchased that are cost effective. So like at the dollar store or general grocery stores. So this provider would really like information on your guys' ideas and recommendations on how to engage the family in reinitiating therapy. What is the best way to ensure a parent is aware of those existing and relevant medical concerns? And then how you also approach a situation when a family says something along the lines of, thankfully, she was out of the hospital in 9 days and was all better. But we also know that prenatal exposure impacts happen long term. So how do we help support that family or address those concerns? So Shayna has us in breakout groups and has put into chat who is doing it. So Kurt, you are taking the first 2 questions, your breakout group, and then Tiffany, your group is going to address that last question. So if you guys want to go into your breakout groups, we'll give you about 15-20 minutes to discuss that. Please take a minute and introduce yourselves. And I'm really excited to share all the resources you guys have. Okay, so we're just going to go over one idea. So Kurt, what about from your group?
My group?
You were the first person on my screen.
Yeah, well, I guess it's a plus and a minus. So a lot of what we talked about for both of the questions, how do we get the parents to re-engage and how do we help them understand or become aware of the past recommendations? A lot of it has to do with just making sure that we have significant conversations where we understand exactly where they're coming from, whether it's an educational level, whether it's how much time they have to spend with the kid, whether it's from a financial level, because there's everything from, are they having to go in to do the OT? And if they are, maybe they don't have the finances or the time to do that. When it comes to understanding the intersection of the CVI and other things that would cause OTs to be there, right? So maybe they've got some sensory defensiveness or something like that, helping them understand on a level that they understand. In layman's term kept coming up, talking in layman's terms to help them make sure they understand what this means and together what it means. And so really just having those conversations and getting doctors and nurses and therapists involved and finding out where the barriers are. Why are we only doing it once a month? And, finding out more about those people and what their situation is so that we can address those issues in a way that will allow them to do what's in the best interest, and really helping them understand the long-term effects of not doing things or doing things and allowing them that choice to be able to do how they're going to do it. So.
Awesome. Great. Thank you, Kurt and Kurt's group. Tiffany, how about one thing from your group?
I think one of the best ideas we had was just simply forming a relationship of trust. It's hard to go into a home. My first comment was I would just be blunt and tell them they're wrong, but that's coming from a mom, and it was nice to hear you know, professional opinions as they state, you know, build that relationship. You can't, you know, you can't make any progress in getting them back into therapy if you're not supportive and understanding, and kind of going along with what Kurt said, just positive affirmations, you know, just stating, I have noticed that you are doing really great at this and there's some progress. Now let's add on to that and let me teach you what you need to do next or what would be helpful next. You know, so just really forming that relationship and then teaching, you know, building up and then teaching and following that same pattern. So.
Well, wonderful. Thank you all for your recommendations. If Kurt and Tiffany, if you guys are the ones who took the notes, if you will send those to projectscope@usu.edu, Shayna will compile those for us. Thank you everybody for joining us. We will be meeting next month. July 10th is our next session, and we will be hearing from Teresa. I probably am going to say her name wrong, so I'm not even going to try, but they're from DHHS, and they will be talking to us about some prevention and healthy habits, as well as some brief statistics around substance abuse in the state of Utah. So hope to see you on the call. Enjoy the rest of your afternoon.